Welcome to the Secure Start podcast, brought to you by the Secure Start Aura apps, supporting trauma-informed care and practice at home and in school.
Any relationship that has an element of vulnerability, of insecurity, of uncertainty is an attachment relationship. I have found in the supervision relationship from a supervisor to supervisee, those attachment dynamics do come out, not just within the supervisee, but also within the supervisor. The supervisor serves as a secure base. It serves as this safe haven to explore different approaches, different parts of the training and whatnot. So the attachment, again, it gave me a framework to think about working with students, with trainees, with supervisees in a stage of their career that will help them understand their clinical work and also themselves a little better. Certain environments, certain people may elicit certain type of attachment patterns. So when I think of attachment-based supervision, I think of it as a relational one where we discuss not only what's going on clinically with cases, because that's the focus of any type of supervision, but how is it coming alive between perhaps you and I?
Welcome to the Secure Start podcast. I'm Colby Pearce, and joining me for this episode is a highly experienced practitioner and psychology educator with overlapping interests with my own. Before I introduce my guests, I'd just like to acknowledge the traditional custodians of the lands I'm coming to you from, the Kaurna people of the Adelaide Plains, and acknowledge the continuing connection the living Kaurna people feel to land, waters, culture and community. I'd also like to pay my respects to their elders, past, present and emerging. My guest this episode is Dr Alex Rowell. Alex is a practicing clinical psychologist in the United States and United Kingdom. He has a wide range of clinical and professional experiences that include working in inpatient, outpatient hospitals, non-profit organisations, multiple college counselling centres, the National Health Service, higher education, and he currently works virtually in private practice. His areas of interest include clinical supervision, mood disorders, self-compassion, teaching, mindfulness, burnout, and gender awareness and education. Alex has presented on postpartum, mental health, multicultural awareness, clinical supervision, psychodynamic psychotherapy, and personality disorders at various conferences. He practices mainly from an attachment-informed, psychodynamic, and humanistic existential lens. He is also a certified supervisor through the British Psychological Society. Well, welcome, Alex, to the Secure Start podcast.
Mm-hmm.
Now, it's interesting. I connected with you through LinkedIn and some LinkedIn posts that I saw from you, and I continue to look at them and just think, oh, what an interesting person you are in terms of the breadth, I think, of the work and the influences that you have, and including. Attachment theory, a big interest and big aspect of your practice, as I understand it, attachment theory, which, if I'm pointing the right way, I did, lines up a little bit with my own interests as well. So I'm really eager to talk about that. Maybe we just start with perhaps if you can tell us a little bit about the work that you do and how you came to be interested in attachment theory.
Yeah. Well, Colby, thank you for having me on this Secure Start podcast. So really excited to be here. And yeah, I'm glad we connected via LinkedIn, which is a really wonderful tool to connect people from all over the world. Here I am in, the US and, in Australia. So it's really lovely to connect. And yeah, so kind of my experience has kind of taken me actually different parts of the world. So I've worked in the US and in the UK for a little bit in Northern Ireland. So I've done a lot of clinical work, everything from working the NHS, which is my most recent post prior to the one I'm at now. But yeah, I've worked in university settings. I've worked in nonprofits, worked for some inpatient, outpatient hospital settings, and I have found it all really lovely, wonderful experiences. I'm working
Mm.
with people from various walks of life, very different cultural backgrounds, identity markers, suffering from certain in different mental health conditions. So not only within the U.S. context where I was trained, actually in Southern California, but I practiced a little bit in the middle of the U.S. and then Oregon, which is a state above California, but then again to the UK, working in a different health system and at a university. I worked at Queen's University for a couple of years prior to coming back to the U.S., which where I am currently. But to your question more specifically, yeah, attachment theory has always been something that has guided pretty much all of my clinical work, some of my teaching as well, and some of my supervision, which I hope we kind of get into in just a moment. But it's always been an interest of mine. I think it applies to all different types of clinical work, working not only with patients, but working with supervisees, working in systems, working in teams, working with, organizations, all those types of things. I have found it very applicable to different
Mm.
aspects. So you could take a psychoanalytic lens, you can take a neurobiological lens, a evolutionary lens, a social cultural lens. I just find it kind of covers quite a bit, like it really does, as far as different perspectives and ways to understand the person in front of you,
Mm.
whether it be someone with severe complex trauma, someone with EUPD, or maybe someone who's just feeling quite anxious or dysregulated in that moment. So attachment theory has really guided kind of my clinical work and part of my professional identity. And I think I was quite lucky in the program I went to, which was very psychodynamic, psychoanalytically focused, which I don't know how it is in Australia, Colby, but there are programs not as much anymore focused on that orientation. What will happen is you have to do analytic training. So people are probably familiar with analytic institutes, not just in the U.S. or Australia, but really all over the world. There's institutes, but that's usually postgraduate training.
Mm.
But my graduate program, I was lucky enough to have quite a bit of therapists, professors, teachers, mentors who are analytically trained in San Diego, where I got my training. So I think, kind of a very kind of narrowing down to the question you asked me originally. It's just something that I feel like it really gets to what's going on.
Mm.
And not just, hey, these are the symptoms, here's the fix. It really gets to the core of all mammals, obviously humans being included in that, and what they're experiencing in the world, how they experience others, how they experience themselves, how they feel, whether they can trust people, whether they're able to repair, whether they're able to mentalize or empathize in some ways. So it's just really a guiding principle in a professional identity for me.
Yeah, yeah, same. I think I refer to it as a guiding framework,
Hmm.
and similarly, I've often thought of it, or right back even early in my professional life, um, as providing a really good framework and really good base for understanding the people in front of me, but also understanding the role that I have, the task that I have as a practicing clinical psychologist with them.
Hmm.
And yeah, you wondered about what the situation is like in Australia. I suspect there's even less psychoanalytic training opportunities here in Australia,
Hmm.
and I have had people like there's a fellow called Peter Blake on the podcast
Hmm.
who's an Australian clinical psychologist, author, but he went to the UK to train at
Hmm.
and I think it was at the Anna Freud um, training school
Yeah.
or yeah.
Yeah.
So yeah, and that's I think generally the way it is here in Australia. Um, Interestingly, with attachment theory, I haven't always thought it was very far into the camp of psychoanalytic thought.
Hmm.
Probably until I've become more and more. exposed to psychoanalytic thought, including
Hmm.
through this podcast. And
Yeah.
yeah, because Bowlby was seen as a bit of an outsider at the time. Object relations was the
Yes.
predominant theoretical orientation amongst psychiatrists
Yeah.
in his neck of the woods. But yeah, as I said, as I have learnt more about psychodynamic work, because it wasn't part of my training, I
Mm.
see very much how
Yeah.
it does fall under that umbrella.
Yeah, absolutely. I mean, think of Bowlby and, Fairburn and Maine, and you think about the shift. The shift became from drives, sexual
Mm,
aggression drives, to people or how they say it, object seeking. That
mm,
instead of we want to discharge energy, sexually aggression energy, now we want to discharge or seek comfort through other people, which I think probably people understand that they get that people seek comfort in others.
mm,
I mean that's how all mammals are. And yeah, there was a nice, I think, a really helpful shift. So object relations attachment theory, I think, really kind of shifted the direction a little bit from
mm,
the section aggression, destruction, death drive to more of a instead of object seeking pleasure, object seeking comfort.
mm,
Yeah.
mm. Yeah, yeah. And
Mm.
I want you've touched on um, how you apply it as
Mm.
guiding principles or an aid to understanding in various aspects of your work. I think I
Mhm.
was particularly interested in the supervision work that you do,
Yeah,
and how you apply it, and are there any particular aspects of attach? Because it's quite a broad church attachment
for
theory.
sure.
It's a
Yeah.
large body of work now. But what in particular, or what parts of attachment theory do you think are important, perhaps in each of those aspects of
Mhm.
your work, but we'll move more into the supervision.
Yeah, yeah. So in regards to the clinical supervision from an attachment perspective, I really got interested in this when I was in the UK at Queen's University doing some training, some research on my own about supervision models.
Mm,
And my experience, in the NHS system, it's banded. There's different band levels. So a band 7, a band 8A, band 8B. And what I experience is usually when providers, psychologists reach a band 8A, they are
mm,
kind of expected to supervise. Then, if you think of your graduate training, I know my graduate training and even graduate training in the UK, those are ones I, most experienced with, with myself in those systems and you kind of, looking in the Australian system, you might get a class on it in graduate program
mm,
if you're lucky. However, you're being asked to do it.
mm,
Usually, for some band 8A therapists in the UK, a couple years after, maybe even faster than that, depending on the pressures of the systems and whatnot.
mm,
So, what I found is just like ACT, DBT, psychodynamic, CBT, there's a framework how to work with people, patients with their depression, anxiety. And I was wondering, how can we create a framework or at least a theoretical understanding of how to work with supervisees? Because people listen to this podcast, think about how many times they have either been supervised, which is probably they have been supervised if they reach this
mm,
stage of training, but more so, how many times have they been asked to supervise?
mm,
And what have their models looked like? So there are some out there, don't get me wrong. There's a seven-eyed model of supervision, there's
mm,
developmental model of supervision, and how mainly therapists supervise is their own theoretical orientation, as CBT, ACT, psychodynamic. So when it came to attachment supervision, I just felt like, as you highlighted just prior to asking this question, that does cut across different orientations and understandings and approaches that I have found in the supervision relationship from a supervisor to supervisee, those attachment dynamics do come out, not just within the supervisee, but also within the supervisor.
mm,
So, the secure, anxious, avoidant, disorganized kind of approaches that what happens is that when we're feeling kind of maybe a little scared, a little vulnerable, a little overwhelmed, those patterns come out in the supervision. Let's say, for example, you struggle with a particular case, or
mm,
you're really nervous about, oh, did I do enough, safeguarding or enough, did I do this intervention correctly? Those patterns kind of come out, like I said, not just with the supervisee, but with the supervisor. So I just felt that some of those patterns in some of the work I was doing as a supervisor, but also some of the research and some of the readings I was doing was coming out because there is a dynamic in there that's similar to therapy. Like we have a
Mm.
therapeutic alliance when working with patients. There's such thing called a supervisory alliance. How strong is it? Will a supervisee, well, hopefully a secure supervisor, be be able to maybe try out an intervention and then come back and report it? How was it? Did I do this okay? Was that all right? Can I explore this? There is the supervisor serves as a secure base. His secure serves as this safe haven to explore different approaches, different parts of the training and whatnot.
Mm.
So again, with the attachment piece, it's not just with the supervisee, it's also with the supervisor. In my experience, the most helpful and your listeners can reflect on the most profound supervision experiences have been the ones that are the most emotionally attuned, reflective, not just come in, here's a didactic, I'm going to teach you this, or okay, we have to talk about patient A, patient B, patient C. Those experiences, I don't think help guide clinicians to their full potential and growth when it comes to working clinically. So
Mm.
the attachment, again, it gave me a framework to think about working with students, with trainees, with supervisees in a stage of their career that will help them understand their clinical work and also themselves a little better.
Mm. I like the idea of the supervisor as a secure base. And I wonder also your thoughts about um, what are some of the, because people bring their own attachment style or styles to
Mhm.
supervision. And
Yeah.
one of the things that, so I would, one of the ways I think about attachment is that people have a predominant attachment style, but they don't
Mhm.
always approach relationships under the influence of that style.
For
It
sure.
really depends very much on what's happening in their contemporary circumstances. And
For sure.
so for example, just quickly,
Mhm.
from my perspective, every the vast majority of adults in April 2020 were
Mhm.
approaching life and relationships under the influence of what we would more we would identify as being some pretty problematic schema or internal representations of themselves, other
Mhm.
people, and their world, so that
Yeah.
they themselves as vulnerable, other people as dangerous, as the world is unsafe, and this very early
Yeah.
in the COVID pandemic. So I'm
Mhm.
just wondering about what you see people bring to supervision in terms of an attachment style and uh,
Yeah.
and whether that's probably likely their predominant way of approaching life and relationships, or whether they're moving on that
Yeah.
continuum a bit, or that spectrum a bit of attachment.
Yeah. That's a really good perspective and good points that you highlight there. I think sometimes people think of attachment styles like you're anxious, you're avoidant, you're secure, as if it's this neat little chart.
Mm,
I kind of conceptualize it almost like a percentage or a pie chart that you might be 45% secure, maybe 20%, avoid in terms of anxious, that you don't just fit into one category. In my experience, researchers do that. It's because it's
mm,
easy to quantify, put in a nice little category. Here, we'll make sure we'll get it published. And here's, make it simplistic in the sense that if it's this quantifiable category. But clinically, when you work with patients, supervisees, certain environments, certain people may elicit certain type of attachment patterns. And my experience has been, like I said, maybe you're 65% secure and then maybe 30% avoidant. When
mm,
distress is quite salient or going on, there might be little secure tendencies, but also some avoidant tendencies. So it's not just one or the other, black or white. So yeah, Colby, I agree with that. Also, one thing as you were talking, how does it come up in supervision? Now, I like to ask the listeners to reflect on their own supervision experience or being a supervisor. Let's say we have an anxious supervisee, thinking about, okay, attachment theory, what does anxious look like from a clinical perspective or with a child? But let's kind of conceptualize it from a supervisee perspective. It may look like the supervisee who is always knocking at your door every time they
mm,
finish a session. Did I do this right? I'm not sure if I did that correctly. What do you think about this? Can you check my note? Can you double check it? that's an example might look like. It also may look like they're calling you at 5 p.m., 5:30 after work day is ended. Is this okay? That again, can I complete this correctly? I'm really worried about this person. And the supervisor may feel a little smothered,
Mm.
overwhelmed. We're using a kind of an analytic term. There might be some projective identification going on.
Mhm.
Then their attachment style gets activated. Like, oh, here we go again. I'm seeing this incoming call or this email again, or I got sent the note back again. And maybe their attachment style comes up. So, for example, if it's a more avoidant supervisor, they may feel overwhelmed, may not pick up the phone, might not answer the door, might say that they're busy. So that's just an example of how it might look in a supervisee, a supervisor. Another one would be an avoidant supervisee. The avoidant supervisee may have trouble engaging with emotional content, transference, countertransference. What is the emotion in the room? They may be hyper focused on maybe certain type of cognitive intellectual approaches and
Mhm.
have a difficulty going there or ask, why do we need to go there? This is maybe what the self-report measure says, like, why do we need to talk about this? They may be very checklist. Sometimes, especially with this type of supervisor, the supervisor is like, they're great. They're going, they got everything, check it, boom, 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 boom. But I have found with those supervisees, they're doing everything right. Like they're passing the training, their practicum or the placement, but the supervisor's like, yeah, there's something missing here. Like,
Mhm.
yes, they're passing on the chart on the, passing all the marks, will go on to the next practicum replacement, but there's something missing here. So, it comes out in different ways in supervision and attachment-based supervision. The supervisor and hopefully supervisor are aware of these dynamics playing out in the
Mhm.
room and what's going on.
As you talk, it sounds like a dance to me. And,
Yeah.
and I'm not the first person to refer to the dynamic between an attachment figure
Mhm.
what usually in the context of my work, a young person,
Mhm.
as a dance.
Yeah.
Yeah, and I think I wonder what others have also talked about it from a singing perspective, and the extent to which you're singing the same song, so to speak.
Mhm.
But I like that the symbolism of a dance,
Yeah.
um, and I wonder what the you could skip right ahead, get ahead to what is the optimal way of dancing with between the
Mhm.
two. But what I guess is I'm wondering about is um, how that looks in terms of a progression
Yeah.
stages towards dancing together in sync, so to speak.
Yeah. Yeah. Well, just like any dance, there's break dancing, there's salsa, ballroom dancing. And what I mean by that, we're going with this kind of metaphor. There's inpatient work, there's outpatient work, there's nonprofit work, there's a pressure from a system work. So, for example, if you have, hey, we have 10 sessions, this is the work we're going to do, that can influence the type of music and the type of movement we have. You
Mm.
might not do long-term work or depth work in 10 sessions. Or if you're an inpatient, you might get one meeting or two meetings with someone. Other clinics, you might get there's no treatment is open-ended. So in regards to this dance, I think it depends on the type of music is playing and the
Mm.
type of dance that you have. So again, getting to these more attachment styles would be getting more to unconscious content, interpersonal content, internal working models, and whatnot. So I think the ultimate kind, if we were to simplify it, is to have a secure attachment relationship between the supervisee and supervisor. Whereas the supervisee, I kind of talked about just a moment ago, is a supervisee can come with some of their insecurities, some of their failures, some of their mistakes, and bring that to supervision and have the supervisor hold that, maybe co-regulate or regulate that, explore that. Hey, how do we try it this way? Or what was going on for you when this patient said this?
Mm.
So the supervisor able to contain and regulate the supervisee, and then maybe kind of put it back to them. Let's try maybe this time, or let's explore it a little more in depth. There are certain settings where that is more able to be done in certain settings that are not. So I also want to understand the realities of some settings are able to do that, some settings are not. But it doesn't mean it's not prevalent. Again, thinking of some supervisions, sometimes it's just, okay, tell me about patient A, B, C, D. Okay, did you do this? Okay, did you fill out this paperwork? Did you do that? Sometimes it's very task focused or line manager focused,
Yeah,
but
administrative.
attachment, yeah, administrator for sure. Yeah. And then, but the attachment piece of the supervision is not. It's more the interpersonal working of what's going on. And it can be a parallel process of what's occurring.
Mm.
So the dance is, making sure that you both are kind of moving to the same music and same kind of rhythm. And yeah, it's hopefully the idea would be to more secure attachment. And like I said, there are times where that may happen in supervision, times that may not happen. But again, is it consistent enough for the person, the supervisee or trainee in this case, feels safe enough to bring up some of their mistakes or insecurities? Because that's, especially from the training perspective, that's where that's done. I mean, think about being qualified or licensed. Once you get qualified, licensed with the state, with the board, with the whatever entity it is, you might not have to seek out supervision. People do, like, and I think it's a good thing. Like I know I do myself, but it's one of these things that, like, who's there to check in on you
Mm.
that you're doing these things, that maybe some of the things that even as you're qualified that you may be nervous about or anxious about.
Yeah, I'm really enjoying listening to you talk
Mm,
about it and thinking about how I would also conceptualize it as
mm,
so you can take on the role of supervision with a particular supervisee. Um, you There is this interplay between you. There's this dynamic between you that kind of it plays out as what we might think is representative of different kinds of attachment style and
mhm,
a relationship that exists between you that that may fit under the umbrella of those kind of classifications of secure,
mhm,
avoidant, ambivalent, and disorganized. And supervision, apart from the teaching and all the other aspects of supervision, is about a dance that comes more and more into alignment, yeah,
mhm,
with each other. Is and
mhm.
I'm I when I hear you talk about it as an attachment relationship, I wonder how what's been the reaction when you've taught, when you've spoken publicly, or even if you've written about
Yeah.
supervision as an attachment relationship. I wonder what the reaction has been.
Yeah, no, that's quite a good question. I think for some people, most of the time the reaction is like, oh, that makes sense. Like, oh, that kind of clicks, that makes sense. And I think most people are kind of receptive to it because, again, if you think about supervision models or trainings, or trainings, models, orientations, there's not a lot there. If I said, like, what's your theoretical orientation? You would be able to pull from that a little bit. If I ask someone what's your supervision orientation or super theoretical orientation, you would probably list your actual theoretical orientation. So I
Mm.
think my experience so far is that most people are receptive to it. And I will say this: supervision, there is a built-in power dynamic,
Yes.
some more than others. In any attachment relationship, there can be, especially early attachment, when we're talking about children,
Mm.
right? There is a power dynamic. There is a differentiation. Now, it's different when we get married or have relationships. There might be a power dynamic, but not in the way of I'm the parent, you're the child. I'm the supervisor, you're the supervisee. In a training perspective, that supervisor holds a lot of power. They can fail them on the
Mm.
placement.
Mhm.
So we have to acknowledge that built-in power dynamic. There's the built-in structural power. There may be other power dynamics playing out in the sense that, for example, they might have a certain identity markers, maybe being, kind of a white man working with someone who is not of a dominant identity or a
Mm.
gender. So
Mhm.
that is a cultural, social built-in dynamic on top of the structural dynamic of supervision. Age is another
Mm.
example. Degree could be another example. So, from an attachment perspective, the earliest, type of Bowlby and whatnot, there is a power dynamic. I'm the parent, you're the child. The
Mm.
supervision has a flavor of that. There is a
Yes.
built-in power dynamic. It's different from, hey, I can fail you on this placement because you didn't meet, these qualifications. It may look a little different when, hey, I'm already qualified and I'm seeking out supervision for professional development. But regardless, there is a bit of a power dynamic. So going back to your question, how do people receive it? I think most of the time people can take A, attachment theory, take B, supervision, and combine it. Like, oh, that kind of makes sense. Like I understand that perspective. Because inherently in a supervision dynamic, there is a power dynamic, just like in attachment style at the beginning, especially with children, infants, babies, adolescents, teenagers, there is a power dynamic being played out.
Mm. Yeah. Yeah. And I guess it also calls for people to be, in addition to the work, to be self-aware
Hmm.
about the relationship that is existing.
Yeah.
Um, and I wonder, there are relational behaviours um, that the the attachment figure deploys, that
Mhm.
uses um, in the context of raising a child, for example.
Yeah.
And I guess I'm wondering what what do those relational behaviours look like when you think of attachment as well, think of supervision from an attachment point of view,
Mhm.
and what does the supervisor do to create this felt sense for the supervisee of a secure base, and to support and encourage alignment with
Yeah.
secure attachment behavior
Yeah.
ultimately.
Yeah. No, that's a really good question. I think one thing that hopefully all supervisors or most supervisors at least strive towards is attunement and attentiveness. Can they attune? Can they are they attentive to what's going on? So tracking not just what's going on for the supervising clinically, but in my context, working in a training, it's like, hey, how are things going with your viva or your dissertation? How are things going in your classes? You're attuning not just to the clinical work, but that because that shows the humanity that usually the supervisee, the trainee, student, whatever, is not just there existing in isolation at the
Mm,
practicum or placement, right? That what happens is you're tuning to all of those things that a supervisee brings to the experience.
mm,
And I guess again, kind of answer that question, like what kind of behaviors do they attune, they're attentive, they're empathic. I would also say another skill, because like in any relationship, especially from attachment lens, is there's going to be ruptures.
mm,
And ruptures are part of any relationship. I think maybe this is one of my clinical hat on. Ruptures are going to happen between parents and children, between partners. Ruptures happen. It's not so much the rupture that could be the problem; it's the inability to repair.
mm,
It's not the initial cut; it's maybe getting infected again, getting
mm,
infected again and again. So an example of a rupture. Potentially a supervisee doesn't get good marks, where a
mm,
supervisee, when they're qualified, gets some really harsh feedback. So that could be potentially a rupture, right? And it's how does a supervisor repair that? For example, I wonder if you have any thoughts about these marks being different from what you put down to compared to what I put down.
mm,
So that is something, or you can even maybe a little more guiding hand would be like, I would imagine maybe there's some, I don't know, feelings or maybe some disappointment or some curiosity around my scores being this and your scores being that. Or
mm,
something, hey, I'm wondering how that feedback's sat with you over this week when we met last time. What was going on for you? So so again, it's my you guys' experience in just kind of working with this kind of model is supervisees remember how you made them feel in your presence. So and that's that secure base, safe base kind of thing, safe haven. They don't remember like, wow, they went to this prestigious university. Oh, they have this many letters, alphabet soup after their name. They don't just like patients, they don't really care about those things. They care about, are you safe? Do you hear me? If we have a rupture, can we repair it?
Mm.
So supervisees, trainees, licensed qualified professionals are similar. So again, it's how do we repair that relationship? Because ruptures do happen, some more significant than others. You know, when I've worked with supervising, there have been some where like, I don't know if this person is going to pass this placement because they haven't met these qualifications. You know, those are the hard ones, right? Like those are the ones that as a supervisor, like, oh, I don't know if I want to do that. Like it's really hard. But there are also supervisees that you get a lot of enjoyment out of, like thinking about working with them and what you learn and whatnot. So it's not just a one-way street. We learn from our supervisees as well.
Absolutely.
Mm.
Yes. Yeah. A couple of things going on in my mind.
Yeah.
One, I'm going to process
Yeah.
while I speak the first, but I do, I guess, getting back to something I said a little bit earlier. Um, I just wonder about, I think, I think everything you're saying, absolutely. I'm completely aligned
Mm.
with what you're saying. I
Mm.
do wonder though,
Mhm.
part of it kind of is suggestive of the supervisory alliance is like
Mhm.
a therapeutic alliance, yeah,
Mhm.
but it's
Mhm.
also like a parent dynamic,
Mhm.
and I do wonder if there is, if you've ever encountered any pushback about in relation to likening the supervisory relationship as a bit like a
Yeah.
parent-child.
Yeah.
Um, Even if you don't liken it that, I guess people think attachment theory, that's all about parents,
Yes.
adults and children. Yeah.
Hmm.
Yeah.
Hmm.
I was wondering about that.
Yeah, yeah, I think so. Yeah, I think some pushback could be, just to be quite honest, is it feels very like you're parentifying,
Mm.
infantilizing,
And
making the super,
infantilizing. Yeah.
yeah, making the supervisee feel, and some of them, sometimes the supervisee is older than the supervisor. You know, for
Mm.
example, this second career coming back and whatnot. So I think it's again, it's not a perfect kind of model to put over it, but I think the piece that I would highlight is there's a power dynamic.
Yeah.
And whenever there's a power dynamic built in a relationship, because there's like a clinical relationship, excuse me, relationship, there is a built-in power dynamic. Now, how big that power dynamic is, there's so many factors to that, can help hinder, strengthen, weaken that relationship. Like, what
Mm.
does it look like? How is it used? How is it discussed in the room? So, yeah, I think there can be, I think that's a fair kind of point to highlight because it's not clinical work.
Mm.
It's not, you're working with a patient and whatnot, but I often found there's a lot of clinical things that do come
Yeah.
up in supervision. Yeah.
Mm. You are, it is a nurturing relationship. A lot of people would think of supervision from a supervisory perspective. I guess if they're relatively new to that role, or and maybe
Mhm.
not, maybe if they've just always practiced this way, is that my my role is to teach and to guide.
Mhm.
And whereas attachment theory is more about support, nurture, grow,
Yeah.
and
Yeah.
and that's what a supervisory relationship or supervisory role is, from my point of view too. And I think, um, and in some ways, that's also what therapy is all about
Hmm.
as well. So, this
Yeah.
probably goes to the broad applicability
Hmm.
of attachment theory as a
Yeah.
theoretical body of theory, but also as a way of practicing and a way of being.
Yeah. I mean, there's no question. There are times where as a supervisor, you have to be quite didactic or quite maybe hands-on or instructional. For example, if there are maybe your supervisees working with someone and they didn't do a thorough enough risk assessment, you might be very instructive, very like, we need to do this, we need to do that. There may be times where, yes, I have to fill out this paperwork where there's an administrative component to it. As you highlight, it's also a nurturing one, and a one that hopefully has attunement, attentiveness, as well. Because being a therapist, being in therapy, working with people, clients and whatnot, is a vulnerable experience, like it
Mm,
is. And what can be more vulnerable than coming up to someone or going into a room with someone and saying, like, hey, this is how I work with this person. What do you think? Well, how can I grow? You're asking for feedback. And
mm,
hopefully you can get it in a constructive way. So excuse me. So yeah, it's you may find it. I know for supervisors that I've talked to, excuse me, they're wearing many different hats. They're coordinating with, the university about this. They are filling out these forms. They are, picking up this client because this person's out sick. Like they're wearing many different hats. Just like clinically, we can sometimes wear different hats as well.
Mm, yeah,
Mm.
yeah. And I guess I'm wondering about being more attachment informed in one's approach to
Mm.
supervision, professional supervision.
Mm.
What you experience and observe to be the benefits of adopting
Yeah.
that framework and that approach.
Yeah. I think the people I have worked with from an attachment kind of supervision lens is the work feels more um here and now. It feels more emotional. It feels more tangible. It doesn't feel as surgical. It doesn't feel as cold or as an exercise going through the motions in a way.
It's
Because we're
relational.
taught it's relational. Yeah, it's a relational. I believe supervision is a relational experience. Also, as a therapist, I believe therapy is a relational experience.
Absolutely.
And there's different modes again, and that's not to say there are different schools that have different approaches and that one is better than the other, whatnot. I guess my experience is going back to the roots, I think, of psychotherapy. It was a relational one. It wasn't, hey, check these boxes, fill out these worksheets, do these things. People get hurt in relationships and people heal in relationships.
Mm,
So think of people who come into your office or anyone's office feeling depressed or anxious. Most of the time, it's not an isolation, a breakup, um, an exciting thing. They got a promotion. The emotion attaches to a relational experience. So as we get hurt in relationships with disappointment, breakups, a loss, we can heal in them.
mm,
So when I think of attachment-based supervision, I think of it as a relational one where we discuss not only what's going on clinically with cases, because that's the focus of any type of supervision, but how is it coming alive between perhaps you and I, from the supervisor and supervisee? Is there a parallel process? I don't know what the term would be necessarily, but just how we have transference and countertransference when you're in a room with the patient, there is an element of transference and countertransference with the supervisor and supervisee. Some people might idealize a supervisor. Oh my gosh, they've written this or like this. They've learned so many. Some people might devalue them. Oh, what do they have to prove? Oh, they have this degree. I'm older than them. This is my second, So those dynamics play out. So my experience is when we're able to get beneath the surface to internal working models, unconscious dynamics, attachment patterns, that's when people it gets really come alive. The work comes alive, and they're able to think of the depression, anxiety, the loss, the separation in a different way than just this is what's happening to me,
mm,
as opposed to this is how I'm feeling about it.
mm, mm. Yes, it encourages perhaps a more humanistic and
Mm.
person-centered approach to the
Yeah,
work
yeah.
in our supervisees. I'm thinking about what's it like? I'm thinking a little bit about challenges here, and what would it be
Mm.
like um, supervising someone from an attachment um, framework, guiding framework, who had experienced relational trauma growing up
Hmm.
with
Yeah,
their parent, one or other or both of their parents.
yeah, yeah. Yeah, so again, there may be some similarities that come out, just like they would come out in the relationship with their partner, they come out with their classmates, with their coworkers. Like it's not in isolation, just in this example, give me with their parents, with their partner.
Mm,
It would also come out in the supervision process. So again, I think as a supervisor, it's to be aware of that dynamic as far as if there's a rupture or disconnect or disagreement, not a good parent relationship. How is that maybe occurring? How is that showing up in the room between potentially a supervisor who could be seen as an authoritarian figure, as someone who is all-knowing, someone who has they have a position of power? How could that play out with the supervisee?
mm,
And it's not necessarily like, I'm wondering if there's a similar pattern with your parents. It wouldn't necessarily be
No.
that, right? Like you might stow that as a supervisory
Mm,
clinician,
mm,
you might stow that and just take a mental note of that. But you wouldn't name it necessarily like that, but you name it, the idea of just like, what if maybe other supervision processes look like? Has this occurred before? What is it like to receive feedback from me? What areas do you think maybe I'm not asking you about or not getting in our work together?
mm.
So again, there's a clinical aspect of it, but it's not like, hey, have you recognized this pattern before? It sounds like something you do. It sounds like your parent. Because that feels like therapy to me. Like
Yeah,
that feels, but it may be not naming that so bluntly, but like naming that here's a power dynamic
the pattern.
potentially.
Mm,
Here's a pattern.
hmm
What do you think of this pattern? Because
mm,
that pattern now may play out between the supervisee and a patient.
yes, of course. And I think, and the other thing that you've mentioned, which I think is really interesting as well, is for the supervisor to be very aware of how their own attachment patterns
Yes.
are brought to
Yeah.
therapy. I wonder if you might comment a
Yeah.
bit about that as a
Yeah.
challenge.
Yeah. You're right. Because when I've done these trainings before, it's usually supervisors, right? So
Mm,
when I propose the idea that, guess what? You're also in this dance. You're not
mm,
stationary. They're not moving you around. You need to be in the rhythm with them. I think there is now the first step is reflection. Like, okay, what does that look like for me? And some therapists have gone to therapy. My program required it.
mm,
We had to do therapy before we can graduate. Some
mm.
programs require it, some do not. I think it's always helpful to be on the other side of the couch to
Yeah,
live what that experience is like.
I agree.
So with the supervisor, 99.9% of the time, they have been supervised.
Hmm
You usually can't finish any type of program unless you
Mm,
get supervision to graduate. So when I'm proposing this is, yeah, thinking about their own styles. And again, some people are quite reflective on it. In my experiences, especially with people, mental health therapists, maybe a little more anxious attachment style. They want to make
mm,
sure that they help. Okay, I'm going to make sure you do this. I want to make sure you pass. I want to make sure all these things to get through the program and whatnot. But that doesn't necessarily mean everyone has that attachment style. There's disorganized kind of attachment style, which I haven't talked about as much for supervisors and supervisees, and the avoidant style. So I think most therapists who are supervisors realize there is some element of they are contributing to the dynamic. Now, some supervisors are okay sitting with that and processing it, and some will be like, I'm the supervisor. This is
mm,
how it's done. Blah, blah. Or they don't care, or they've done it for 20, 30 years and they're kind of like out to lunch and supervision. So just like that, that's what I'm saying. Sometimes there's no oversight like there would be when you're actually getting supervised. But yeah, it does encourage them to reflect. So I have
mm,
found some supervisors are like, yeah, that makes sense. This is kind of my style. This is how it comes up for me. And then some supervisors who are resistant to it. And that's
mm,
information as well, right? Like that's data as well.
mm. Yeah. While you're talking, one thought that comes back to me from something you said earlier was that is wondering about the extent to which people even think about how what guides their supervision,
Mm.
and people can perhaps practitioners in this space can talk more easily about what guides their clinical work, but yeah,
Mhm.
but then
Yeah.
when put into a supervisory role, what is the overarching guiding framework that informs that?
Yeah.
Yeah, that approach.
Yeah.
I think like it's similar and different to therapy. A lot of people with good supervision,
Hmm.
I'm hearing through this podcast and through
Hmm.
direct experience, people will say that good supervision feels a bit like therapy
Yeah.
in a sense, and particularly when talking about holding space for people, holding
Yeah.
respective spaces for people. And one of the challenges that I encounter in my clinical work particularly is that in clinical work, the clinical work that I do, the therapeutic relationship is a really enriched relationship.
Hmm.
Yeah.
Hmm.
And you're ultimately wanting to be redundant in the life of your client. Yeah.
Yeah.
But if they're not experiencing the same or similar levels of enriched relationship with others, they can be quite resistant. In my case,
Yeah.
with children and young people, quite resistant to the
hmm
idea of um, of making you redundant in their life,
Yeah.
so to speak, in
Yeah.
finishing it up. And in supervision, it's a bit like that too.
hmm
Sometimes we have a time frame. Sometimes, if it's for a university program, you're supervising,
hmm
whatever. There's a time frame, and that. But then, you talk about when professional supervision for colleagues, that can often be open ended.
hmm
And I I wonder whether a relational attachment informed, even psychodynamically informed in a more broader sense,
hmm
uh, supervision process. I wonder about challenges and your thoughts about how the supervisor also makes themselves, well, they make themselves both a secured base but
hmm
ultimately redundant in the
Yeah.
life of their supervisee.
Yeah. Yeah. I mean, that's a good point. I think when I think of supervision or being supervised, and I think a lot of people do who are in this space, they're a mosaic of their supervisors. So think about your training, maybe professor. They take bits and pieces from their supervisors that they've worked with, they've trained with, and they just apply it to their style. So again, to that point, it's how to be redundant. I guess just like in therapy, you are with the client, again, I'm stereotyping here, maybe, 60 minutes a week, once a
Mm,
week there. Okay. So the idea is with therapy, it also was supervision, that 60 minutes lasts longer than that. You actually take that person, that
mm,
therapist, that supervisor with you throughout your day, throughout your work, throughout your life, that they not necessarily become a voice or become part of you, but they're there, they're accessible.
mm,
It's are they able to integrate that person into their internal working model, into their object relation? Are they able to kind of, yes, they're not physically there. A supervisee, when they're working with a client, the supervisor is not physically there most of the time, unless they're observing or one-way mirror, whatever. But they're maybe like, what would my supervisor do in this moment? What is the protocol? What did they say that they should do?
mm,
So seeing the redundant, yeah, that's true, right? There is some of that, but it's once the therapy or the supervision is over, how does that person still live within your professional identity? I mean, I
mm,
think of some of my supervisors, and there's a couple in particular that if we're talking 13 years ago now, that I
mm,
often think about quite often. How would they approach this? How would they think about that? So I
mm,
haven't spoken to him in years, but
mm.
they're with me, just like attachment figures, internal working models
Exactly.
are. Yeah, yeah,
Yeah, I was thinking just like parents, that process of growing up and individuation and
yeah,
tolerance of separation
yeah,
and
yeah, yeah, yeah,
yeah, because
yeah.
there's a fear, I would say, because this also happens in the clinical work that I do is with children and young people,
Yeah,
predominantly children and young people who can't safely be cared for at home at,
yeah.
for a period of time or maybe not throughout their growing up years. So they're in out of home care. And there's always been this um, fear of the therapeutic relationship, fear of it becoming an attachment relationship, and
Mm,
and and the child becoming dependent in the,
yeah.
in the way that a child does in an attachment relationship. And there's been over the last 30 years, there's been periods of my career where that's been very much seen as a bad
Mm,
outcome. Yeah, but
mm,
what we're talking about here, and this is the way
mm,
I guess I've always thought, is that they need a good attachment experience somewhere.
hmm
Yeah,
Yeah.
you know, if our supervisees come to us with a complex attachment history themselves, as you say, they're going to be practicing. They need a model. They need a
hmm
representation of what a secure being a secure attachment figure looks like, feels like, what they project and what it feels like to have
hmm
that. Because it's a healing relationship. a
Hmm.
secure
Yeah.
attachment relationship.
Yeah. Yeah. Yeah.
I Yes, I'm thinking and
Mm.
talking at the same time, which
Yeah.
usually usually I do a lot of my thinking while I'm
Yeah.
listening as well.
Yeah.
Um,
Yeah. Juggling.
yeah, juggling.
Yeah.
So, there's much food for thought here,
Hmm.
Alex. And
Hmm.
I guess I'm also wondering about, are there any cautions that you would provide about who might um, adopt this approach to supervision in terms
Yeah.
of, it could be in terms of their knowledge and understanding of dynamics and the
Hmm.
dynamics of relationships, their understanding of, of where
Yeah.
how that is felt by supervisees or experienced by supervisees. And are there, are there certain supervisees that you would say would actually benefit from different types of supervision approaches to an
Yeah.
attachment informed one?
Yeah. Answer that last question. Yes. So one model of or theoretical model of supervision is developmental model.
Mm,
So, for example, your supervision style. So we're putting attachment supervision to the side for just a moment. Your supervision model will be guided on where that trainee, supervisee, professional is in their career development. For example, a first year doctoral student, master's student in their first practicum or placement, you might be a little more hands-on. You might do a little more guiding, more didactic. You might be a little more involved, which again, if we were to put this back attachment lens on, you'd be a lot more scaffolding. You would do a lot more guiding. The attachment relationship from an infant or even at 6, 12 month, 18 month, 20, 24 months looks a little different from someone who's 13 years old,
hmm
right? So a first year supervisee in their first placement, first training, your style might look a little different. You might not ask some of these deep questions, interpersonal process, but it may look different from a fourth or fifth year doctoral trainee.
mm,
They would be at a very different developmental stage of that. So there's that piece, right? There's another piece from the supervisor's perspective is have they also done some work?
mm,
If the questions that are going to be asked of the supervisee, are they going to be comfortable with that answer?
mm,
If they say, oh yeah, I felt a little hurt, or I felt kind of blindsided when you gave me this feedback, you know, if the supervisor's response is like, well, this is how I feel, this is, I've been doing this for a while compared to other training, that's an intellectual response. That is not that now have shifted out from a relational dynamic and got behind the position of the supervisor, a power position. So that I would also encourage the supervisor to think of their own attachment style, what comes up when they're really stressed or dysregulated. As you know, Australia, United States, in the UK and Ireland, health systems are under tremendous pressure.
mm,
And often people are voluntold to supervise. So not only do they have their full caseload, but now they're asked to take on a supervisee. So again, that's when it goes back to, can I do attachment form supervision if I'm so busy, so inundated with all the clinical work, and now I have to supervise because it's
mm,
part of my Band 8A requirement. That looks a little different from like, oh, I really want to supervise and I can manage it in my caseload with my current patients. So again, so there's the setting, there's the supervisee's developmental arc, and the supervisor's own, let's call it awareness of their attachment style. So
mm.
it's there's multiple pieces to it.
So that then I guess suggests that it is not always the time and the place or the
That's true.
person to
Yeah.
be, and I'm wondering, just kind of as a final um, um, question as such,
Mhm.
whether there are other particular types of other theoretical traditions or approaches that you think are very helpful for people who take on the supervisory role, either voluntarily or they're made to, uh, should be aware of, maybe be trained, receive some training in, so that they like a bit like therapy, you
Mhm.
you you can adapt your approach somewhat to the client in front of you and
Yeah.
what their
Yeah.
needs are.
Yeah. and piggybacking off of that, you as a supervisor would adapt your needs to what the supervisee is. A third year supervisee, as far as how much you observe them, critique their clinical notes, may look very different from a first year, may look very different from someone who's redoing a placement. So yeah, I mean, there are certain times that for example, a CBT structured supervision might be really helpful. So we've done this type of supervision before where every, excuse me, every kind of supervision session, the supervisee will come in with 3 or 4 clients. There are different columns, different categories, presenting issue, work done, next appointment. And having that type of structure can be really helpful. Like there's no doubt that can be really helpful. And again, just like theoretical orientation, if you have maybe 3 to 6 sessions, maybe 10 sessions, you might not do psychodynamic work. That's the environment might not be there. Just like the other under the spectrum, let's say you've been seeing someone for 20, 30, 40 sessions. Maybe some of those cognitive approaches that you have been doing, you might find yourself sputtering and not, where do I kind of go from here? So it's all relative. Like it is all relative to the setting, to who the supervisee is, who the supervisor is, their capability and ability. So yeah, there'll be times where it'd be hard to approach. I mean, most analytic programs or institutes you have to be supervised. And, when we think of supervision back when, it was kind of first kind of thought of how we kind of practice it today, there was a blend of therapy and supervision, but now those things are a little more separated. So yeah, there may be times where you don't, talk about these ruptures, these repairs, attentiveness, because the supervisee is so dysregulated because they forgot to check something. You wouldn't be like, oh, you're really upset right now. And it's like, maybe I need to do a safety assessment, or I need to call this person back. Like excuse me, that would be an example of, yeah, maybe it doesn't apply to this approach, or this is not the tool to use at this moment.
Yeah. But notwithstanding all that, it strikes me that the role of supervision is to enable the supervisee to be able to launch into the world with confidence and with an understanding that they can come back to top up their cup when they need it. So even though you might adopt a different style, one of the primary primary aims of supervision still remains able to be articulated or understood through an attachment lens.
Yeah, absolutely. Right. That they can come back to you. And I'm sure there are times where maybe you or some of your listeners have consulted with supervisors that they're not that placement anymore, blah, 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 but it's a difficult case. Or the presenting issue, like, oh, this person is suffering from a disorder, eating or eating disorder. I don't have experience, but this other supervisor I used to work with has that. Maybe we'll give them a ring. We might call professional consultation, kind of thing. But you go back just like a child would in a new environment. They're exploring it. Who are these people? What are these objects? Oh, is mom or dad there? They're there. Maybe I'll go back to them, recharge, fill up a little bit, and go back out again.
Yeah. It's a very interesting way of thinking about it. Again, notwithstanding my great interest in attachment theory and the use of it as a guiding framework, not so much to my shame, but I really probably haven't always turned my mind to the supervisory relationship, viewing it through the lens of attachment theory. I probably have done it, how we often practice in a certain way, and then we kind of, the penny drops that we're doing this, but we haven't always attached that nosology to it, or those ideas to it, and I think for me that partly that's because of what you were saying, the thinking around the prevailing ideas around what a supervisory relationship is meant to be versus what a parent-child relationship is and is meant to be. And you don't, and a kind of an anti-patriarchal approach to practice as such. But I think this has been a really helpful and really good conversation, because no matter what ideas we might be put forward to say, well, you shouldn't be trying to be an attachment figure in the life of your trainee. You really are. You really are.
Any relationship that has an element of vulnerability, of insecurity, of uncertainty is an attachment relationship.
I think that's a really good point to finish up on. Thank you, Alex, for taking the time to appear on the podcast.
Yeah, thanks, Colby, for having me. Appreciate it.